at the ASH 2025, I also had the pleasure of hosting How I Treat session about the treatment of patients after upfront quadruple therapy. This is a patient population that we're seeing increasingly more often, given the widespread adoption of quadruplets in the last few years. Early progression are uncommon, but when they do occur, we're dealing with a very high-risk disease. There's not a lot of prospective data on how to treat those patients. They are not represented in meaningful numbers in any prospective clinical trial reported to date. What we tend to do is to essentially adapt the evidence. For those patients, more than any other, it's important to have introduction of agents with new classes, and particularly the BCMA-directed therapies, either through CAR T-cell or a bispecific T-cell engager, if that's available, come very handy. And we also show at this meeting that introduction of T-cell redirecting therapy for those patients in second line greatly associated with better progression-free survival. There are other creative options. For example, the patient that happens to be 11-14 can have some exquisite response to BCL2 inhibitors. So oftentimes there will be a circumstance where we use, for example, venetoclax in combination with carfilzomib if that was not part of the initial therapy. But most importantly is for the community to have understanding that this is not your garden variety patient progressing after one line of therapy. Those progressions, particularly the first 3 years, carry a very poor prognosis, and those patients need to be prioritized for a clinical trial enrollment. And now with the therapies with new mechanisms of action, something that is now possible given the greater availability of CAR T and T-cell engagers.